Hello, my name is Dr. Susan Robbins. The class is Drugs and Society. Say hello to future viewing audiences again, class. Hello. Okay. We are very lucky we have here with us today Dr. Stratton Hill, who is the former head of the pain clinic at MD Anderson Hospital. He's also one of the original lecturers in this course when we started teaching this many, many years ago. So we are very fortunate to have him back. He's going to be talking today about the proper and improper use of medications that are prescribed for valid reasons and are sometimes used improperly, among other things, as well as talking about use of drugs to mitigate pain. So please welcome Dr. Hill.
Thank you, Dr. Robbins. This evening we're going to talk about abusing drugs and appropriate use of drugs. I'm currently working at a homeless mission for men with alcohol and drug problems. And we see a lot of abuse of these drugs. Now, these men are not patients as such. We do have a convalescent care center there in which we do have some patients in there. Usually these are men who've gotten beat up or gotten run over, or they don't know what happened to them. And also we have people who just get sick. So the first thing I did when I got there, believe it or not, was to organize a social service department. And we have 3 master level social workers working there now. And so in the context of this type of practice, and also what I think you'll see in ordinary social work, I don't know what ordinary social work is, but outside of a mission like this, you're going to run into people who have pain problems and have a problem getting the pain treated. One of the reasons why that is because the drugs that we use to treat the pain are also drugs of abuse. So that's what we're going to be talking about tonight. And let me see if I can work this. One of the things that I want to emphasize in this whole lecture is that our society determines pain relief. Think about that. The society determines how much relief of pain that you're going to get. Now, so what do we want? What does pain treatment have to do with drugs in society? Well, let's just look at some ways that pain is treated. First of all is physical therapy with skeletal manipulations and soft tissue manipulations, acupuncture, acupressure, and the TENS unit. TENS unit is a unit in which electrical stimulation goes into the skin. We have soft tissue massage therapists, hypnosis, guided imagery, and relaxation. We have nerve blocks, have surgery, have radiation therapy, and we have analgesic drugs. Now, in that context, we're going to be talking about analgesic drugs, and analgesic drugs mean drugs that relieve pain. Now, analgesic drugs are going to be the prototypic type of legal drugs that are abused by our society. And here's a short list of drugs in society. First, we have herbal preparation, so-called complementary and alternative methods of treatment, nutritional supplements, and no prescription is required in those type drugs. We have over-the-counter drugs, and there are some restrictions on over-the-counter drugs now. For instance, some of these drugs, like drugs used for colds where you have decongestants, are used to make illegal drugs. So now we have these drugs behind the counter, and you have to go and ask the druggist for that and sort of register with them. But there's no medical supervision. over-the-counter drugs. Now, dangerous drugs are drugs that you have to get on prescription. All prescription drugs are considered dangerous drugs. And they're dangerous because they would be dangerous when they're not used under supervision. That's why they're called dangerous drugs. They're also called legend drugs. And by that I mean in the package insert, the little piece of paper in there, it says this federal law requires that this be prescribed by prescription, by a doctor. And that's the legend that's in there. Then we have controlled drugs. This is a one step above the dangerous drugs. In other words, the manufacture and the distribution is regulated by the United States Department of Justice, DEA, the Drug Enforcement Administration. So tonight we're probably going to be talking more about these scheduled drugs. And they're called scheduled drugs because the Drug Enforcement Administration has them in 5 different schedules. Schedule 1 is a drug that has no medical uses. And marijuana is in that category. A lot of people will take issue with that about marijuana having medical uses. Schedule 2 drugs are the hard narcotics, the morphine, the hydromorphone, and drugs like that. So we're going to be talking mostly about that type of drug. Here's some operational definitions that I'd like to give to you. When we say legal and illegal drugs, we're talking about the legality of a drug that's determined by its cultivation, manufacture, distribution, and sale. And that's defined by the political jurisdiction that it's in. For instance, in Texas, medical marijuana is not legal. In California, medical marijuana is legal. Arizona, it's legal. So the jurisdiction you're in will determine whether or not it's a legal drug or an illegal drug. I want to distinguish between drug misuse and drug abuse. You'll see more drug misuse than you will drug abuse. And that is, people do not take the drug in compliance with how the doctor has ordered it. For instance, take a drug 3 times a day, or take a drug with meals. And then the patient comes back to see the doctor, and he's only taking one pill a day because he only eats 1 meal a day. The doctor assumes that he's going to eat 3 meals a day. So the patient unwittingly was not in compliance with what the doctor ordered. Now, drug abuse is drugs that are not taken or used for medical reasons, and that's commonly referred to as recreational use. And what are the types of drugs that we see that are abused? In general, they are mind altering. That is, it alters the mood, the sensorium, and when you get into sensorium, you're talking about your senses. People take different hallucinogenic drugs and they see funny things or hear funny things. That's the sensorium is altered. The mood altering is you get on a big high or you get on a big low. And consciousness, you can either be sedated or you can be super stimulated. Drugs that are like methamphetamine are stimulants, the central nervous system stimulus. A major exception to all of this are anabolic steroids. Now, anabolic steroids are male hormones, male sex hormones. So where do you see that? You see that in athletes. Mark McGuire just recently admitted that he used performance-enhancing drugs. So that's another group that's abused. And they use all of these drugs, however, are usually psychoactive. The anabolic steroids are not psychoactive. They do not change the mood or senses and so forth. But remember that any drug or any substance can be abused. So you never can tell. Sniffing glue and things of that sort is abuse of a substance. And what are some of the categories of the mind-altering drugs? Anesthetics. These are sleep-producing drugs. That's unconscious pain relief. That's the best pain relief in the world, to be asleep. Now, where did you just recently see where that was abused? Can you think right off? What's the moonwalk? Who did that?
Michael Jackson.
That's it. Michael Jackson. What did the doctor from Houston give Michael Jackson that they're claiming killed him? Propofol. You don't use that outside of a hospital. That is an anesthetic drug that puts you to sleep. And so that's a case of abuse of a anesthetic drug. Anxiolytic, sedative, hypnotics, what are those? These are drugs like Valium, Ativan. It relieves anxiety, but it can make you sleepy. Opioids or narcotics. I'm sure that they've mentioned to you that the proper term for the use of these drugs is opioids, not narcotics. Narco means to sleep, and of course sometimes you do get sleepy, but basically these drugs are used for conscious pain relief. Central nervous system stimulants. That's a hyperactive consciousness and motor activity. That's people who are revved up. They're going to go on forever. They don't sleep for days. This is methamphetamine and things of that sort. Cocaine. The cannabis. What is that? That's marijuana. Exaggerated feeling of well-being. So you see that all of these are sensory and mood-altering drugs. And alcohol, of course, feeling of well-being, progressing to cognitive impairment. And it's dose-related. In other words, the more you take, the more likely are you're going to be cognitively impaired. And that's pretty much true of all these drugs that we're dealing with. Now, drugs that are used to treat medical conditions that are also frequently abused. In the case of the central nervous system stimulants, it's methamphetamine or methylphenidate or Ritalin. That's for the hyperactive disorders and narcolepsy, either one of those. Then the anxiolytic sedatives of the benzodiazepine, Valium, Ativan, that's for anxiety, seizures, sedation, alcohol withdrawal, and muscle spasm. So it has a wide spectrum of use for legitimate medical purposes. One of the problems with, and not a problem basically, but people who try to commit suicide with using anxiolytic drugs is that they're protein bound. So when you get into the bloodstream, it binds to the protein. So most people are very disappointed when they wake up after they've tried to commit suicide, because it just makes them sleep a long, long time. You have to take an awful lot to commit suicide that way. And then the opioids, morphine, hydromorphone, meperidine, pain and conscious sedation. So those are the three categories that you see most often abused. Now, methadone is also used for drug abuse treatment maintenance. You've heard of methadone maintenance programs. This is a substitution of a long-acting opioid that is used to treat people who have most of the time addicted to heroin. All right, I want to say a little bit about the legitimate use of these drugs and the abusing them related to technology. And it's related to a drug delivery system. In other words, how drug abusers deliver drugs into their body. So why is that important? It has everything to do with the euphoric effect abusers get from the drug. For optimum effect, the drug must be delivered rapidly and soluble in fat. In other words, most abusers are looking for rushes. And the more fat soluble the drug is, that is, it will go into the fatty tissue, the higher the rush. And most of the central nervous system is fatty tissue, so it goes into the brain and spinal cord very rapidly. Optimum routes are lung and blood vessels. People sniff, smoke, and use it intravenously. So that's the preferred route. And what drugs are best suited for this type of thing? One is, the first one, cocaine, preferably crack, used by smoking, sniffing, and intravenous. And then heroin. Heroin is generally used intravenous and is highly fat soluble. The drug, and the third type of delivery system is in drugs that you've heard of, that you've heard of OxyContin. This is where a delivery system is incorporated in the drug itself. And the drug is bound to some sort of matrix or some sort of framework in the pill or the capsule that it's in, and will, once you take that by mouth, it then will release that portions of that pill over a period of 8 to 10 to 12 or sometimes 48 hours. So that a 48-hour dose of drug is in that one pill. So what happens with the drug abuser? The drug abuser then takes that pill, hits it with a hammer or something, crushes it, destroys the delivery system, and has a 48-hour dose all at once. And this is what happened with all the stuff you heard about with OxyContin and a lot of the other drugs like that. So that is one in which the abuser gets to the medication by destroying the system that's in the medication itself. The other way is drugs that are incorporated in a patch. You've probably seen patch. Women who are taking estrogen use an estrogen patch. Y'all are too young for that. But there is a patch that is put on the skin used for treating severe pain. And in that patch is contained a drug called fentanyl. Now the system fails that test, that requirement of rapidly administrating the drug. So what happens with the abuser? The abuser then takes it and takes the patch, destroys it, and gets the medication out of there. And that's how they do it in order to get the medication out of the patch. Now I'm going to show a couple of videotapes right now, and this is going to be of patients that were treated for pain, and each one of them was going to illustrate a certain problem related to the treatment of pain with these types of drugs. All of these patients are they do have cancer, but this could be anybody else for pain for any other reasons. There are going to be two of them. One was made in 1988. Y'all were in kindergarten at that time. And the other one was made in 1997. And I want to call your attention to that because I want to point out something related to that time differential. But then we're going to, after we see each, first after the first tape, we'll stop and ask some questions. And then we'll look at some of the messages that patients are sending out to their healthcare providers, and some of the concerns that they have, and some of the treatment they get at the hands of the people who are treating them. So pay attention to each one of them, and then we'll go out of that. We'll go with the first one will be my word.
This is a tape about living. Specifically, it's about cancer patients living a productive life with chronic pain controlled by narcotic analgesics. It's also about problems these patients face getting adequate pain control with narcotics. Ideally, cancer pain is controlled by controlling the cancer, that is, removing the cancer to remove the cause of pain. Unfortunately, in a significant number of patients, treatment may fail. In others, treatment may be successful, but it causes persistent pain. Still another group of patients, presumed free of the disease, the cause of pain cannot be explained, but nevertheless requires adequate treatment. These are the situations of patients with which this tape deals. Patients with severe, unrelenting pain for whom treatment of the cause of the pain is not possible. These patients must be treated with systemic analgesic drugs. As the severity of pain increases, strong opiates or narcotics must be utilized. Few physicians would deny that narcotics have an important role as pain relievers in the practice of medicine. Their use ought to pose little problems for the practitioner. For in 1680, Sydenham wrote, "Among the remedies which it has pleased Almighty God to give to man to relieve his suffering, none is so universal and so efficacious as opium." Yet there are few physicians who would deny their uneasiness, to say the least, in prescribing them for their intended purpose. Why is that so? What makes this class of drugs uniquely sensitive for the physician to use? The fundamental reason probably is the failure of our culture to distinguish between the individual who has a need for the pain-relieving qualities of the drug and the individual who may use them for recreational purposes and ultimately abuse them. Unfortunately, the negative image of these drugs dominates both the physician's and the public's concepts about them. This is reinforced by society's efforts to control their illegitimate use. The language of the laws controlling the legitimate use of these drugs in medical practice often contains the same language as the laws controlling their illegitimate use. The practitioner is therefore confused and is intimidated to use them for their legitimate purposes. Let's look at some cancer patients' experiences and determine what must be done to improve control of pain where removing the cause of pain is not possible.
How you doing, Dr. Hill?
Hello there, David. How you doing?
I appreciate you coming out.
Well, listen, thank you for inviting me. Boy,
David Baldridge is a 40-year-old manufacturing jeweler.
Come right on in.
In 1985, a soft tissue sarcoma of the lumbar region was diagnosed. The tumor extended into the left side of the pelvis with a mass effect on the colon. It proved to be inoperable. Mr. Baldridge has been treated with chemotherapy and with radioactive gold seeds. Between February of 1986 and 87, his pain progressively increased, and he was referred to M.D. Anderson's pain clinic.
Can you straighten that out?
Sure. Yeah.
His medication was changed from a combination of oxycodone and acetaminophen to morphine. Like many patients, Mr. Baldridge's pain therapy became a point of contention with some of his physicians. It was insinuated that his interest in having his pain relieved was evidence that he was a drug abuser.
Me and Dr. got into it about pain medicine because he said I was taking too much, in which I'd already asked him before to go to the pain clinic because I thought they could do me a better job. And in fact, me and the surgeons got into it because one of them wrote in there that he thought I was addicted to drugs, and I wanted that took out of my record because I didn't think that was fair, you know, because they was giving me medication and I was running out and I still wasn't getting any relief at all from my pain.
How's your pain now?
Now that the medicine that you got me on, it's pretty well got it stabilized.
And what do you take?
I take my MS Compton, and then I take my morphine sulfate and my Valium, and then I have one that I take for my bowel to keep my bowels moving.
Right. How much of the MS Compton do you take?
I take 25 of those in the morning and 25 at night.
Okay.
And
so that's 750 milligrams twice a day, or
yes, sir.
1,500 milligrams of MS Compton. Now, what about the morphine sulfate? How much of that do you have to take in addition?
I take that usually anywhere from 4 to 6 times a day during
the whole 24 hours?
Yes, sir.
Now that his pain is under control, the patient is much more active. Instead of lying in bed most of the day as he did previously, he makes jewelry in his shop, drives his car, and even takes care of his mother, who's a stroke victim. It should also be noted that his drug dose escalated only after his disease progressed. It was merely tailored to meet the intensity of his pain. Cecil Hurley had always dreamed of attending his 20th high school reunion, especially now that he had cancer. In 1978, this 40-year-old former air traffic controller was found to have a lesion of the right maxillary sinus. A biopsy revealed adenocystic carcinoma. Mr. Hurley was treated by partial maxillectomy, followed by radiation therapy. In 1981, the cancer metastasized to the left upper lobe of his lung. A thoracotomy was done, but the disease was inoperable. Chemotherapy was administered. In August of 1984, bilateral pulmonary involvement was discovered. Another course of chemotherapy was given, but the disease progressed in spite of it. At this time, the patient began experiencing severe pain. His family physician treated it with a combination of acetaminophen and codeine. However, the doctor would only give him prescriptions for very small quantities. This intimidated Mr. Hurley, so he endured extreme pain rather than demand relief. However, when it got unbearable, he sought help from VA or a private hospital. In the course of receiving it, he was humiliated by questions and innuendos about the severity of his pain and was made to feel like a drug addict.
Well, I tried to go to independent hospitals and in places that bragged kind of about things that they were doing, but they weren't showing me anything. They were giving me the feeling I was a drug addict or just somebody that wanted me to some way of getting a fix.
Were you in pain all the time?
Yes, sir. I was in pain, and I'd had several doctors telling me there was really no way of stretching the fact of pain or how that I was going to be, how that I was able to express my matter of pain, or, you know, it's just my word against theirs, sort of a.
During this period, Mr. Hurley was depressed and spent most of his time in bed. In May of 1985, he was referred to M.D. Anderson's pain service. 90 milligrams of control-release morphine was given every 12 hours, with occasional doses of immediate-release morphine, and his pain was controlled. This controlled-release dose was increased gradually over 2 years to 180 milligrams. Occasionally, he requires rescue doses of 90 milligram immediate-release morphine. Here's how Mr. Hurley described his life after his pain was adequately controlled.
It got on a program that I feel real good about. I went ahead and had my class reunion and enjoyed myself. I've, for about the last 2.5 years, 3 years, I've been able to live a quite normal life to an extent of least pressure and least pain. My family has, we've had vacations together. I've been able to live with a certain more comfort than I would have if I'd have continued on the present path I was on.
For God gave His only begotten Son.
Early on in his life, Olin Walters felt a calling to be a Baptist minister. At the age of 49, he was well into this calling when in 1982 he began having pain in his right hip. His family physician diagnosed bursitis. 2 years later, the symptom proved to be an early warning of soft tissue sarcoma of the lumbar and thoracic regions. His initial treatment was preoperative chemotherapy, followed by resectioning of the lesion. When the tumor continued to grow, several additional courses of chemotherapy were given. In May of 1985, radiation therapy began. In August, a radical resection of the mass was done. An abscess developed in the operative site, leaving him with a large open wound which has failed to heal. This lesion is the source of chronic pain and was treated with intravenous hydromorphone, controlled-release morphine, and diazepam. In February of 1987, bilateral pulmonary metastases were found, and he was admitted to the hospital for a right thoracotomy. The plan was to remove the lesion in the right lung first, and then the left. Following the first thoracotomy, the pain was treated with a dose of narcotics less than what he was receiving to control the pain for the ulcerated tumor in his back. Reverend Walters was referred to the pain service 3 days after being discharged following that first thoracotomy. The referral requested his pain be treated without narcotics and suggested that he be put on a detoxification program.
That was expressed totally. That was expressed by the surgeon in charge. He said to me, and again I quote him, "You're a dopehead, and I'm going to dry you out while I've got you in here." And the actual amount of medication that I received following the operation, the thoracotomy, was less than what I was operating on a daily basis and functioning at my work. At the first time, the doctor actually wrote a chart and put it on my mirror at the time that my medication could be administered. And I would punch the button. It was said PRN. I would punch the button and tell the nurse that I needed my medication. And she would say, "It's 2 minutes." And this happened a number of times. And I said, "It'll take you 2 minutes to get it ready. Please bring it. I'm in pain." I'd call back in 2 minutes. She would answer, "We'll get the medication briefly." Never when this occurred did I get it sooner than 30 minutes.
That was on the first time?
On the first time. The second time, as I said, was totally different. The pain medication was administered at the time it was supposed to be. Sometimes the pain had built up fairly high, but was not intolerable.
Reverend Walters exemplifies a patient whose pain control by narcotics allowed him to return to his occupation, but he showed no need for drug doses beyond those required for relief of pain. Drug dosage was steady, and there were no symptoms of drug-seeking behavior, and he certainly experienced no euphoria. At age 34, Priscilla Simmons had a good marriage. She and her husband and their 10-year-old daughter lived a comfortable life in East Texas. When sexual intercourse became persistently painful, she was disturbed and consulted her family physician. Pelvic examination revealed a left perivaginal mass. Biopsy and histological examination proved it to be a neurosarcoma attached to the left vaginal wall. She was referred to MD Anderson for treatment.
I came here with a tumor, and I had surgery and went home for 13 months. Everything was fine, and I came back last year in December of '86 with a reoccurrence, and I had surgery again, and then they sent me home, and then when I came back for my 6 weeks checkup, the tumor had reoccurred, at which time they suggested that I have radiation treatments, and I had 4 weeks on the neutron machine, and then they did radiation implants and also removed the tumor at the same time in late February. And then after the surgery and everything, I went home and was progressing well.
Mrs. Simmons did well for about a month. Then in March of 1987, dyspareunia and rectal pain recurred. Examination by the family physician revealed necrosis of the left vaginal wall, thought to be secondary to radiation therapy. She was treated with antibiotics, and her lesion improved. Her pain, however, persisted and was treated with a combination of hydrocodone and acetaminophen every 3 hours, and she also took 2 regular acetaminophen tablets every 2 hours. This combination amounted to a potential toxic dose. 6 months later, in September of 1987, Mrs. Simmons was readmitted to the hospital because of a severe left pelvic pain. It had been precipitated by an attempted intercourse following a 6-month abstinence necessitated by her disease. At this time, the pain service was consulted. The patient was given 20 milligrams of morphine sulfate intravenously, and this gave her relief. On the basis of the results of the intravenous morphine, the pain service recommended she be given 180 milligrams of controlled-release morphine every 12 hours with a 90 milligram rescue dose of immediate-release morphine every 4 hours as needed. 1,500 milligrams of choline magnesium trisalicylate twice a day and 75 milligrams of anitriptyline at bedtime were prescribed.
Your pain.
The gynecology fellow responsible for the care of this patient had severe reservations about the narcotic recommendations because there was no evidence of demonstrable disease.
Well, one doctor told me that there was nothing that they could find as far as the tumor or anything like that, but that he felt. He never doubted my pain, but then there was one doctor here that, caused a lot of problems. Really caused. I thought, well, this is all in your head.
Tell us about that.
Well, she really made me feel like I was a head case, that I needed to go see a psychiatrist. That, and then when, on top of that, when you prescribed the dosage for me to take, and Miss Thorpe had been in my office, in my room that morning, and told me what I was going to take. You'd been, y'all were so thorough with telling me, this is what you're going to get, and this is when you're going to get it, and and all this. And that evening when I brought my medicine around, it was half of what you had told me. And we had them call. I had the nurses call Dr. Edwards, and Dr. Edwards told the nurses to do what you had said. That was where their orders were to come from. And every time she came in my room, she just really made me feel like I was very unimportant because it was all in my head.
With her pain under control, Mrs. Simmons has gone from lying in bed all day to being able to do her housework and enjoy her family.
This is wonderful. It can, I don't have to hurt for the rest of my life, because when you've hurt for 4 or 5 months, you get to thinking you're going to do this the rest of your life.
Mrs. Simmons' ordeal illustrates the difficulty cancer patients in pain have getting adequate treatment for pain relief when the traditional biomedical model fails. Under these circumstances, physicians are reluctant to treat pain with narcotics. Her ordeal also illustrates that most physicians do not consider outcome of treatment a valid criteria for the use of narcotics in treating cancer pain.
The pain was inadequately controlled in my estimation because of actually lack of medication in many cases and difficulty in getting it for whatever reason, I don't know.
Dr. John Benvenuto is a 42-year-old pharmacologist employed at MD Anderson. In June of 1986, he experienced a sudden onset of diarrhea, followed by anorexia, bloating, and malaise. Over the next 2 months, he lost 30 pounds. A CAT scan showed several metastatic lesions in his liver. On physical examination, he was found to have a mildly elevated temperature, labored respiration, and a mass which occupied 3/4 of the abdominal cavity. He was diagnosed with metastatic adenocarcinoma, probably of the neuroendocrine category. Dr. Benvenuto was treated with chemotherapy and embolization of a branch of the right hepatic artery with a gel foam powder. The procedure caused extreme discomfort and constant pain. While he was hospitalized, he required very large doses of narcotics for pain control. Chemotherapy was discontinued, but he received several embolizations to his liver, and that resulted in considerable improvement of his pain. When discharged from the hospital, he required 4 milligrams of hydromorphone every 3 hours. Since then, his condition steadily improved, and although his pain had lessened, he still required narcotics for control. July 1987, the pain service was asked to see the patient. A dose of morphine equivalent to the dose of hydromorphone he had been taking was recommended. This was calculated to be 30 milligrams of control-release morphine every 12 hours. In addition to this, he was given 10 milligrams of amitriptyline every night. He was also prescribed a rescue dose of immediate-release morphine, but never used it. On this program, Dr. Benvenuto's pain is being controlled.
I don't know that I have pain. It's being controlled adequately now, so I don't have any, I'm not suffering at all.
Prior to his pain treatment, Dr. Benvenuto felt useless. Now he's able to work in his lab and can even drive himself to the hospital.
The medication doesn't hamper me at all. I can drive back and forth to work, shopping, recreation, whatever it is I happen to want to do.
Dr. Benvenuto's case is a good example of how morphine can be used in relatively small doses in patients whose prognosis may be long-term. The bias against morphine, except in terminal treatment situations, should be put aside. Its use, when indicated, regardless of stage of disease, should be encouraged. This tape shows a variety of cancer patients groping with their individual pain problems. If there is a commonality illustrated, it is that narcotics are extremely beneficial in restoring a quality of life the cancer patient would otherwise not have. This is specifically illustrated by the following points. Many patients taking narcotics for pain control are able to function in their usual jobs, participate in activities with their families, and live, essentially, either a normal life or at least a fulfilling one for the period of life remaining. Maintenance narcotics for pain control seldom, if ever, produces euphoria. Tolerance develops slowly, if at all, with maintenance narcotics for pain control, and incremental increases in doses are small. When it is necessary to increase the dose of narcotic, it is usually due to progression of disease with increased pain intensity. Incremental increases are usually significant, 25 to 50% higher. Patients who require high doses of narcotics when pain is severe during the course of their disease will reduce that dose when pain lessens or abates as a result of treatment. Even when no reason for pain can be determined, for example, the biomedical model for pain fails, patients can and do experience pain requiring narcotic management. The pain is quite likely to be of nociceptive origin. Patients complaining of undertreatment, for example, failing to get relief with the dose prescribed, or who make atypical claims about their experiences of pain or their response to pain treatment, are often treated as street addicts by physicians and other healthcare providers. Attitudes of physicians and other healthcare providers toward patients in pain may influence the quality and the quantity of pain relief given the patient. The physicians and other healthcare professionals' own standard of moral values may influence the quality and the quantity of pain relief that a patient receives. Unfortunately, physicians and other healthcare professionals have an attitude that narcotics use that is persistent or habitual is a bad practice, no matter what the reason for their use.
What must we do to correct the problems illustrated on this tape? As I've said before, I believe that most physicians want to provide optimum pain control for their patients in pain. Let me make a few suggestions. First, an intense educational effort directed towards physicians and other healthcare professionals, teaching them the difference between individuals abusing narcotics and those taking them for pain. Dr. Morgan has suggested that physicians have become phobic about narcotic use, and this phobia has become fixed in their customary behavior. He suggests medical re-education alone is not sufficient. Educational efforts might better be directed to changing mistaken attitudes about drug use and abuse pervading the entire American culture. Second, re-educating physicians about the pharmacology of narcotics and their side effects, especially respiratory depression. A significant number of patients undertreated for their pain simply do not receive an adequate dose. Third, improve the understanding of the relationship of regulatory agencies, both state and federal, to physicians using narcotics for pain control, and work to change the language in statutes to distinguish the drug abuser from the patient taking narcotics for pain.
Tape? Did you learn anything? We'll talk about this a little bit later. I want to show you now another aspect of the problem of pain treatment and some of the societal problems that physicians face in dealing with this problem. Could we go ahead and have the second videotape? Well, actually, they're not videotapes. They're DVD. See what? I'm stuck in that.
Week, there was fierce debate in Congress over controversial laws just passed in California and Arizona allowing patients to use marijuana to relieve pain, which brings into sharp focus tonight's lead story. Imagine living every day in excruciating pain, Then imagine there was a simple treatment to relieve that pain, but your doctor wouldn't give it to you. That's exactly what's happening to millions of Americans who suffer from chronic pain. Doctors are afraid to use one of the most effective treatments available, high doses of narcotic drugs. They're afraid of turning their patients into drug addicts, even though it's been proven that pain patients rarely become addicted. What's more, doctors are afraid of being branded as drug pushers and losing their medical licenses. One internist who was not afraid to prescribe narcotics was Dr. William Hurwitz. That was until his medical license was revoked.
It just struck me as such a scandalous outrage that these patients are systematically neglected, that they're orphaned by the medical system, that nobody wants to take care of them.
Dr. William Hurwitz has successfully used narcotics to treat more than 200 chronic pain patients, victims of failed surgeries, accidents, and illnesses, patients who were unable to find relief anywhere else.
They were told, oh, you're just drug seeking, you're just an addict. Not only were they injured, but they were insulted.
Let's talk about the number of pills you prescribe to some patients. For over a 2-year period, you prescribed to one patient more than 90,000 narcotic pills.
Dose is irrelevant. The right dose is whatever works that produces tolerable side effects.
What do you say to someone who's sitting out there who says, come on, doctor, 90,000 pills?
If it takes 100 pills a day or 200 pills a day to relieve the pain, that's what it takes. There's just no way for me to say, let's undertreat him, let's make him suffer.
Many of those patients would be dead if it hadn't been for Dr. Hurwitz.
Dr. Stratton Hill of MD Anderson Cancer Center is one of the country's foremost experts on the management of pain.
We don't distinguish between the legitimate use of these drugs to treat legitimate medical painful conditions and the abuse of them, so that society thinks these drugs are intrinsically bad. And therefore, anybody who takes these drugs is almost considered prima facie a criminal.
Eddie Andrews was getting narcotics from Dr. Hurwitz until the doctor's license was revoked. Now he's running out of drugs and terrified of facing the future in pain.
I'd say 80% of the mornings that I wake up, maybe more than that, the pain is so horrific, I cannot move. I can't move.
Eddie Andrews was injured in a car accident 9 years ago. Since then, he's had 3 back operations. And after each operation, he says the pain got worse. Just sitting down for this interview was a painful ordeal.
See, it's from sitting. It's from sitting too long. Could you give me that cane, Mr. Browder, please? It's right there. I know you want to get out of here.
No, I'm fine. Don't worry about it. Has it subsided at all?
It has. It has.
It took Eddie Andrews 10 minutes to sit back down again.
It's like this for you all the time?
I've been like this for 5 years plus. And I've been through some terrible bouts of depression.
How do you get by?
My wife, my son, there's pills.
60 of these pills is what Eddie Andrews takes every day. That's more than 400 pills a week. Strong narcotic drugs like morphine and methadone.
Do you get a rush from these things?
Absolutely not. None whatsoever. I don't even know that I'm taking them except that I can feel the pain decreasing.
The fact is, studies show pain patients like Eddie Andrews don't experience drug euphoria. They don't get high. And according to several studies cited in leading medical journals, pain patients rarely, if ever, become addicted to narcotics. But still, some doctors don't accept Hurwitz's approach.
Narcotics are a crutch. They don't really get to the problem of the pain.
Dr. Warren Kuntz and Robert Nebeker oversee the Virginia Medical Board, which held hearings and took away Hurwitz's license. In its final report, the board raised serious doubts about Dr. Hurwitz's practice and questioned whether some of his patients were misusing their drugs.
If you've ever had narcotics for something, you'll know what it makes you feel like. It makes you feel good.
Are you suggesting that they're taking these things to get high, to feel good?
No. No. But there is a right way to go about controlling pain.
Was it at all the concern of the board that he was turning his patients into drug addicts?
No, not particularly. I think that the practice was felt to be a danger.
I think the fact that there was a potential for substance abuse in the prescribing of narcotics would always be a concern.
Let me ask you how Dr. Hurwitz first came to your attention.
There was a report that there was an increased level of narcotics being distributed to a particular pharmacy in Northern Virginia.
A drug wholesaler reported to the DEA, the Drug Enforcement Administration, that this family-run pharmacy was ordering unusually large quantities of narcotics. And when DEA agents went there, they found that the pharmacist, Jerry Danoff, was filling 80% of Dr. Hurwitz's narcotics prescription.
I was told on one of the many visits to my store by the DEA that there was only 2 reasons that they knew of that patients would get the amount of drugs they got from me. First reason was they were addicted to the drugs, and the second reason would be that they were selling them on the street. There was never any medical reason that they would need that amount of drug.
They were that straightforward in saying that?
Yes, they were.
Danoff says the DEA came to deliver him a message.
I think they came in to try and scare me away from this type of business. It was obvious they were only interested in Dr. Hurwitz and his practice.
15 months later, the Virginia Medical Board took away Dr. Hurwitz's license to practice medicine, saying he excessively and indiscriminately prescribed narcotics and that he failed to realize that 4 of his patients were abusing or selling their drugs. The board also cited the fact that 2 of his patients died and that drugs Dr. Hurwitz had prescribed were found in their systems. But it was careful not to blame Dr. Hurwitz for their deaths. Nevertheless, his practice was termed dangerous. And the danger in the way he practiced is precisely what?
The findings of the board are that he had incomplete diagnosis, incomplete evaluation, incomplete examinations. He was not monitoring these patients effectively, and this was a danger.
I think that's flat wrong. I mean, the patients who I treated for pain were all patients with documented severe syndromes that caused their pain. They had missing limbs, they had many surgeries, they had problems for which I had records that went back 5, 10, 15 years.
Why do you think the board revoked your license?
They've never seen, and they don't believe, that these patients really could need the number of pills that I prescribed. And that it boils down to, they counted pills, they're afraid of these pills, they're enforcing, in effect, the same attitude as the DEA.
That attitude of the DEA and the medical board's finding that Dr. Hurwitz was practicing bad medicine has had a chilling effect on doctors across the country. A recent study found that more than 50% of doctors were afraid to prescribe narcotics, even though they acknowledged that their patients would benefit from them. That reluctance to prescribe narcotics may be justified. Last year, more than 120 doctors who were prescribing, or some say over-prescribing narcotics for pain, had their licenses revoked or suspended.
I think it's part of a strategy of intimidating doctors. I think that the priorities of the DEA and the priorities of the Board of Medicine are, let's put a lid on this. They view me as something equivalent to the Medellin cartel. Let's stamp out the source, and then we won't have the problem.
But the problem, according to pain management expert Dr. Stratton Hill, who testified on behalf of Hurwitz, is that state medical boards are ignoring the facts.
We have to do something about the problem of regulatory boards insisting upon standards of practice that are based upon prejudices, biases, and misinformation. The board has almost unbridled power, and they do whatever they want to. That's what's so scary to doctors.
What did his patients tell you during those 4 or 5 days of testimony?
The patients who he had testify for him felt that he had done them a lot of good.
Did it work?
Well, the patients seemed to feel better, sure.
Isn't that the bottom line?
Well, the problem is you're treating patients with potentially dangerous drugs.
4 experts testified that he practiced medicine in a manner that was consistent with the standard of ethics in the medical community.
His 4 experts.
But these are recognized people in the field.
Well, wait a minute now. His own expert said that his practice was purely unconventional. Unconventional.
Right, but unconventional doesn't mean it's wrong.
No one else is doing it that way.
But if no one else is doing it and it works, maybe everybody else should start trying it.
Then what he needs is a careful clinical trial to try and see if this is as good as, if not better than, the way that others are treating the pain.
Remember pharmacist Jerry Danoff? After the DEA investigated him for filling Dr. Hurwitz's prescriptions, his license was also revoked by the state of Virginia, and he was fined $10,000. To keep his drugstore open, Danoff has had to hire a pharmacist to fill prescriptions.
The DEA are basically a group of policemen, but now in what they've done to myself and Dr. Hurwitz, they're basically creating medical policy, which I don't think we should allow policemen to do.
The war on drugs has turned into a war on pain patients. These patients are told, go home, suffer, don't bother us, and the patients are extorted into killing themselves because they can't get what should be available to anybody who needs it.
Which brings us to the case of David Kavillian, who was a patient of Dr. Hurwitz. Kavillian was severely injured in a car accident 10 years ago. He made this video 4 weeks after Hurwitz lost his license and he lost his access to medication.
It's pretty damn stupid that the only person I can get to help me, they turn around and take his license away from him. No, Dr. Hurwitz isn't the only doctor that can help. He's the only doctor that will help because all the rest of them are a bunch of scared wimps.
The following day, Kavillian committed suicide, blaming the DEA, the Virginia Medical Board, and others for his death.
Suicide was not what I wanted. Pain treatment and control is what I wanted.
His wife said that she was certain, she had no doubt in her mind, that if Dr. Hurwitz's license had not been revoked, her husband would still be alive.
Well, you know what I'll say? I think the Board of Medicine, as tragic as this is, the Virginia Board of Medicine may have saved other lives by this action.
But patients like Eddie Andrews say what the board did is not saving him, it's hurting him. And the hurt is real.
You ever get to the point where you say, I can't take this anymore?
Every day.
Have you had any success finding a doctor to replace Hurwitz?
No. There's not a doctor in Maryland who is going to even want to see me. It's a hopeless situation.
Dr. Hurwitz recently got his medical license back, but there's one major catch. He is not allowed to prescribe narcotic drugs to anyone for at least a year.
Like the first one that sold up your hand. How about the second? How about like the second? Okay. All right.
I'm not sure what you did with it, but the microphone seems to have fallen off.
Oh yeah, you're right. Okay, let's see. Well, one of the things I want to emphasize to you is that one of those, the first one was made in 1988. And the second one was made in 1997, 96. Did things get worse from 88 to 96?
It seems like on the video that things, got worse. That there was more oversight, less willingness to prescribe the medication.
Okay. Were you struck by, in the first tape, the young lady, the red-headed lady, how she was treated? She cried while she was being interviewed because of the degrading behavior on the part of one of the physicians that was taking care of her. Any other things that struck you about either one of those? In other words, you thought things got worse with the second case, and basically they did, because doctors began to try to improve pain treatment, and this meant that they were using more and more of the opioids or the narcotics, and the DEA didn't know what to make of this. To them, it was nothing more than, as the pharmacist said in there, there's only two reasons that you have this. Is one, that they're addicted to the drug, and secondly, they're selling them on the street. So the problem got hardened over that period of time. Now, Dr. Hurwitz went back into practice and went into a pain practice again. And what do you suppose happened to him? Okay.
Did he get his license revoked again?
Yes, but worse than that. He ended up in the federal penitentiary. I went up, they said that, I testified for him in the first time around, and I testified for him in a criminal proceedings against him by the DEA. And he was 62 or 3 years old at that time, and he was sentenced to 25 years in a federal prison. Fortunately, the Fourth Circuit Court of Appeals overturned that ruling, and they dropped a lot of the charges. And he then got a lighter sentence, but he did spend about 4 or 5 years in prison, and he's no longer in practice. The other thing I want to emphasize to you is the response of that Virginia board to the suicide. What did they say? They said, well, yeah, that's pretty bad, but we think we did some good. The other thing that I wanted to point out to you is that in some of these, well, both films showed that, in the first one we said we didn't think doctors paid much attention to outcomes. People got better. That's what the whole thing's all about. And in the Virginia board, Ed Bradley said that the doctor, his wife said if you hadn't taken his license away from him, he'd probably still be living. Yeah, but we think we did some good, potentially, nothing definite. But and also they said, when he, in response to him saying, well, what did the patient say? The patient said, well, they got better. They were under control. That was totally ignored. Okay, let's look then at some of the, let's see if this is going to work here now. We need to skip over those two. Oh, okay, here they are. So let's look at some of the messages from the videos. Chronic pain interferes with or even prevents activities of daily living. This poor guy that was trying to do the interview with Bradley could hardly make it. Just look at all the things that every one of these patients, their life was interfered with because of the pain. Chronic pain destroys personhood. What in the world does that mean? We're going to talk a little bit more about what personhood means, because excuse me, in just a minute we'll talk about that, because I think this distinguishes between what we see as pain and suffering. In other words, we oftentimes hear those two words together, pain and suffering. Well, what's the difference between pain and suffering? Do you always have to have pain to suffer? We'll talk a little bit about that. We'll talk a little bit about whether or not a body suffers. Chronic pain interferes with and stresses interpersonal relationships. That's an understatement of the year. Chronic pain affects and effects family members. You saw some of the family members, particularly that patient that was so emaciated. His wife was a beautiful woman, and yet she was burdened with this grotesque-looking husband, even if he was able to get around because the pain was under control. I doubt seriously she wanted to go out in public with him. So family members, and I almost, sure that she would prefer not to go out with him. Chronic pain threatens the future. How many times well, I don't know, since you're not in practice, you probably haven't started to ask how many of your patients did something, but patients come often say, I want to have improved quality of life so I can see my grandson graduate from college, or I can see something accomplished in the future. So pain threatens that. Patients experience pain, had difficulty getting relief. How many of those, almost every one of those patients expressed some problems with getting adequate relief. Hospital professionals' behavior towards patients experiencing pain was hurtful. The lady said that every time that doctor came into her room, she thought she was just unimportant. Patients seemed perplexed about the treatment they were experiencing. The minister, he can understand why he was being called a drug addict. It's kind of interesting, because one of the things that minister did, in addition to his preaching and so forth, was to be a drug counselor. So it would be kind of unusual for an active drug addict to be counseling others, although I'm sure that's happened. Doctors and nurses seem to have reservations about administering the drugs ordered and or suspicious about the patients. And this carries through not only while patients are in the hospital, but even after they get out of the hospital, when they have to go get their medications at the pharmacy or go to the doctor's office. The body language of the healthcare professionals, the nurse, the receptionist, and even the doctor, by innuendo and so forth, send a message to the patient about what they're doing. Image of the drug as a drug of abuse dominated the actions of the doctors and nurses. In other words, they were driven by their concept of the drug as being a drug that caused harm. And who does it cause harm to? It's a potential harm in our society. And I thought that the doctors on the Virginia board also illustrated how ingrained and how much the image of these drugs as drugs of harm that are ingrained in part of our society and our culture. And this is one of the problems in terms of improving treatment. The behavior of caregivers stigmatize and degrade the patients. It is almost all patients who have pain feel that they are stigmatized. It was instated and inferred that patients were drug addicts. Caregivers seemed to want to punish the patient. The minister called for pain medications. He didn't get it till 20 minutes later. I'll show him. Okay, we'll stop right there. I think we'll need to take a break at this point, and we'll come back to this next And that was right. Okay, in there I said, and some of the things that we see from those tapes is that pain destroys personhood. Now, the concept of personhood will be on this next slide when they put it up there, has helped me quite a bit, because this helps distinguish between pain and suffering. And I think it's helped me in my interpersonal relations with patients and so forth. And I think for social workers, it'll also help you, because these are things where there can be losses. In other words, let's say that someone has hit you with a baseball bat. You have pain. You really don't suffer. But when do you pass over from pain to suffering, or it may be that you have both at the same time? Do you always have to have pain to suffer? This will show you that you don't have to have pain to suffer. People who have chronic diarrhea suffer, but they don't necessarily have pain. If you can't get off the commode and you have to spend all day on a commode, which some people do with ulcerative colitis or Crohn's disease and so forth, that's a pretty suffering situation, but there's not necessarily associated with pain. But this is something that I got from Eric DeSales, which he calls the typology of personhood. Persons have personality and character, and they can lose that. That's subject to loss. A person has a past. A person wants you to honor that past. Take a veteran who was on Iwo Jima and helped raise that flag. That person is very proud of that. If you try to take that away from them, or if you do take that away from them by degrading that patient, then that's a problem for them. A person has a family. Now you can say, well, you work in a homeless shelter, what do you mean they got a family? But they had a family, and they've already lost it. That probably did cause a lot of suffering. A person has a cultural background. Now, a body doesn't have all this. That's what personhood is all about. A person is a composite of all of this. A person has roles. You're the breadwinner, you're not the breadwinner, you're the caregiver, you may be the mother, you may be the father, the uncle, the brother, sister. That's your role. If you lose it, that's a problem. If you're in pain and you've got a brother that you played ball with and can no longer play ball with that person, that's a loss. A person has a relationship with himself or herself. It's what you think of yourself. A person is a political being. That can be of value to you. Persons do things. Bodies don't do things. Persons do. Persons have regular behaviors, and they oftentimes expect to do those things that they do. That can be taken away. Every person has a body image. Sometimes we would have patients, there may be a lady who has a mastectomy, but if she didn't have any reconstruction of her breast, backing the car out became a problem because she unconsciously had an image of her body, and that body image is altered. So that can be a problem. Every person has a secret life. I was giving a lecture one time in El Paso, and after the lecture, a nurse came up to me and she said, "Boy, that's sure true." Said, I had a patient one time that said after she got some bad news and that she was not going to live and so forth, and she was not in good shape, but she said, "I have got to go home. I've got to go home for just a few hours." And she said that she confided in her that if she didn't get to go home, there was going to be a scandal in that town when she died. And so the nurse made a pact with her that she would let her go home. So she went home and came back with a garbage bag full of letters. And it was a pastor's wife had been having an affair with a banker in town. So she couldn't, and she made the nurse promise she'd get rid of those letters. We see things every day about people who have a secret life and they get exposed. Every person has a perceived future. And this is one thing that we talked about before in terms of personhood. You're looking forward to graduation. You're looking forward to a grandbaby or whatever. And every person has a transcendent dimension. Every person has a concept of something that's transcendent. So this has helped me over the years to look at things in terms of dealing in interpersonal relationships. Now let's go back to medical drug use and drug abuse. And let's just look at the images of morphine when it's used medically. It's highly effective to relieve pain while a patient remains conscious. This is not, you don't have to be unconscious. You don't have to be sedated. You don't have to have drowsiness. The physician can get you to a place where you will not be a zombie. I've often had patients say, "You're not going to give Mama morphine, aren't you? We don't want her to be a zombie. We don't want her to be not able to have interpersonal relationships with us." Well, I'm going to give Mama morphine so she can have these interpersonal relationships. When we see the adverse effect of somnolence or drowsiness or sleepiness, it's usually with the onset of therapy. In other words, you start the patient on this, and for a day or two, they may be sleepy. On the other hand, they may have had sleep deprivation. They haven't slept in 2 weeks or 2 months because of the pain. You give them a pain relief, and they sleep for 17 straight hours. And the relatives oftentimes think, "My goodness, what's wrong with Mama? You've killed her." And so this is, you can get past that part of it. But the image that it has is an adverse effect that dominates our thinking about this. And I showed you on that film what Thomas Sydenham said in the 17th century, that among the remedies which it pleased Almighty God to give man to relieve his suffering, none is so universal and so efficacious as opium. Now, opium is a precursor of morphine. Morphine is made from opium. At that time, they didn't have morphine. They didn't have anything but opium. So the medical use of a drug is negatively influenced by its image as a drug of abuse. Now, the images of morphine as a drug of abuse, it's used for non-medical purposes. And we usually say that's recreational for mood and mind-altering effect. Remember that people who abuse drugs most of the time are not patients. They're just individuals who are looking on this for recreational purposes, for the mood-altering effect. Then the harm to society by individuals that use the drug. You see in that film that we showed you there with the Medical Board of Virginia, the other doctor, the two doctors, the one on the left said, "Oh, but this is a potentially dangerous drug." Well, in actuality, there's about 6 to 9% of the general population is psychologically dependent or addicted to the mind-altering drugs. Now, they can be legal or illegal. As far as if they're on heroin, that's an illegal drug. And heroin is preferred for a drug of abuse because it is so much more soluble in fat, and then the brain and the nervous system is mostly fat, it's phospholipids, so that it's absorbed and you get a bigger rush than you do with morphine. All heroin is what's called diacetyl morphine. So that has to be metabolized in the body in order to take off those two acetyl radicals And that's what makes it more soluble than morphine. It's just a derivative of morphine. But then there's a perceived damage that is from these drugs, and in that any exposure, you know, you're not going to give mama morphine because she doesn't want to die as a drug addict. Any exposure whatsoever will ineluctably pull them into addiction. This is totally wrong. That it takes more than that, and we'll go into that in just a minute. Image of opioids is harmful results in patients in pain, especially chronic pain, receiving inadequate relief. And earlier on I pointed out that the number of individuals harmed by the illegal use of opioids and other mind-altering drugs pales in comparison to the number of patients in pain who cannot get access to adequate pain treatment because of current restrictions on opioids. Now, they don't have to be actual restrictions. They can be perceived restrictions. It's just like was said in the second tape there. The regulatory boards are made up of individuals who have this image of drugs as being harmful, and this is what's so ingrained into our society. And I'm going to talk a little bit later on as this being a societal problem that we're probably not going to change anything until we change the societal constructs that we have about the use of these drugs. And I've said common societal wisdom attributes abuse of opioids solely to the mood-altering euphoric effect of the drug. Let's just talk a little bit about euphoria and dysphoria. If you notice the man that was being interviewed on 60 Minutes there, he asked him, do you get high on these drugs? He said, no, I don't get high. All it does is take my pain away. And I wouldn't even know I took it except for the fact that I get pain relief. The vast majority of patients who take these drugs for medical purposes get dysphoria, not euphoria. You heard the member of the Virginia board said, have you ever taken narcotics? They make you feel good. I bet that guy never had a narcotic in his life, because that's not what you get reported from people who are taking them who have a legitimate need for them. They do produce euphoria, and we'll talk a little bit about tolerance in just a minute. And I will say now that that's one effect that you get tolerance to right away. And tolerance, we'll talk about a little bit later, means that it takes more to do the same thing. So if this dose, let's say 10 milligrams of heroin, gave you a big high, and you took it every day for a week or so, probably you're going to have to increase that to 15 milligrams in order to get that high. So the tolerance to the mood-altering effect occurs very rapidly. We'll talk a little bit about that. So basically, you've got to distinguish between euphoria and dysphoria. The vast majority of patients actually get dysphoria on this. Now, that dysphoria may just last a day or two when it's initially started, and then you get over it and you get to where you can take it and it doesn't have that effect. So what is addiction? That's not a very good term, because the World Health Organization has taken that term out of their lexicon. They took it out in the 50s, and it's dependence is what we're talking about. And there are two types of dependence. There's physiological dependence and there's psychological dependence. Physiological dependence is just that the cells in the body have become adapted. This is called a neuroadaptation to the presence of that drug in the body. And if you take that drug away, the body has a physiological reaction to that, which is called a withdrawal reaction or abstinence reaction. And that's where you have sweating, you may have abdominal pain, you get stuffy nose, you get diarrhea, and things of that sort. That's physiological dependence. And that's not necessarily bad. In other words, if you have to take opioids chronically, you're going to get physiologically dependent. That is not bad. That is not a behavioral problem. It's psychological dependence is when you get a craving and a compulsion to take something or to use something in which you know good and well you're going to have, it's going to cause you or somebody else harm. So there's a big difference between physiological and psychological dependence. Psychological dependence is the, if you're going to use the word addiction, is what you're talking about when we talk about addiction. It is where the person is taking them in spite of the fact that it does you harm. Physiological dependence, it is not doing it to take you harm, to make you, to harm you. Yeah.
Well, we've talked about it here, and I've made that distinction between physical dependence and, I don't like the term addiction either, but what we talked about is that addiction is a behavioral pattern of drug seeking that is chronic, compulsive, and people sometimes describe the fact that they crave the drug, but whatever the negative consequences are, they've reorganized their life around that drug. And that's what you're calling psychological dependence, essentially.
Yeah.
Is that it's a behavioral
In other words,
pattern.
yes, it only has, psychological dependence only has behavioral components. However, a person who does that often enough can get, the body then becomes used to that, the presence of that drug, so they will have a withdrawal reaction when they do that. Now, the way I like to illustrate this in terms of the difference between abuse and the medical use of these drugs is that the abuser is taking these drugs to get away from reality. Reality is painful for them. They want to get away from the pain. The person who takes these drugs because they have pain and for legitimate reason, they're taking them because they want to deal with reality. And this drug then brings them back into a situation in which they can deal with reality. They can pay their bills, they can do all the different things. Another problem that's because of the misinformation, the prejudices and biases against these drugs is that, say, for instance, a person can't drive a car because of the pain. And then they get their pain under control and say, good, well, I can drive the car. Oh, no, you can't. Because your mind is all scrambled up because of the drug. That's crazy. I have a videotape of a young lady from Fort Worth who would drive back and forth to MD Anderson from Fort Worth on massive doses of a narcotic or opioid, given, at one part of it was given intrathecally into the spine, into the spinal fluid, and the other part, and then she'd take additional doses intravenously. She drove by herself. She came down. She had no problems whatsoever. So, what this does for the person who has the pain problem is to put them back to where they can deal with everything they have to deal with on a daily basis. Now let's talk a little bit about tolerance. And I'd said before that tolerance was simply, it requires a higher dose of a drug to produce the same physiological effect. Substance abusers rapidly develop tolerance to the mood-altering effect of psychoactive drugs. And that's the reason why they have to have a bigger dose all the time. They become tolerant. They don't get that high. Also, there's some drugs, say for instance cocaine. Cocaine is tied into the dopamine system in the brain, and when you take the cocaine, the dopamine in the brain is removed from the cells, and you're not going to get another high until the dopamine rebuilds itself. So cocaine users know that if they take the cocaine, get a high, that and it doesn't last that long, they want another high, then they take another dose of cocaine, chances are that it's not going to give them a high because that dopamine hasn't come back into those cells. So there's a lot more to tolerance than just saying that it takes more. There's a differential tolerance. The respiratory depression, you get a rapid tolerance. In other words, a person comes into the emergency room with a kidney stone. That's one of the worst pains that you can have. And you give that person, it takes that person 500 milligrams of Demerol to relieve the pain. You remember Dr. Hurwitz in that videotape, Ed Bradley said, "Come on, doctor, what do you say to somebody that says that you prescribed 90,000 pills for that particular person?" And he says the dose is irrelevant. It's whatever it takes. Because pain is a natural antagonist to the analgesic effect of the drug. So the more pain you've got, the bigger the dose has to be. And you have to give them whatever it takes. Now the other thing about that particular point in that videotape was that he said he gave 100 pills a day or 60 pills a day or something like that. That was in the days before pharmaceutical companies were making pills that were of greater strength. At one time we only had a 5 milligram tablet of oxycodone. So if you're going to give if somebody needed 25 milligrams, you have to give them 5 tablets. If they needed 50 milligrams, you had to give them 10 tablets, and so on. So now you've got 10, 20, 30, 40, 50, 100, or whatever size tablets, and you don't have to give them all that. So at that point in time, that was a problem in terms of the number of pills that he had to have. So the mood elevation, I said that you do get tolerance to that. Now going back to the respiratory depressant effect, that's how you die with these this medication. It stops the respiratory center in your brain, and so when you give enough of it, it will absolutely stop that. Now actually what happens in anesthesia these days, now most all of it is done with narcotics, so that patients are put to sleep by a combination. Actually, they use drugs like propofol that Michael Jackson was given, along with fentanyl, and fentanyl takes the pain away. The propofol takes the sensorium and the consciousness away. And so in that case, you do have to breathe for the patient. That's what the anesthesiologist does. You put them on a respirator, and while you're in operation, the patient is being breathed for by the machine. So that's the effect that it has. But if you're just treating somebody who has a lot of pain, then you give them like the person with a kidney stone, You give them that, but let's assume that 10 minutes later they pass that kidney stone. And they don't have any pain. You've given them a lethal dose of narcotic. What are you going to do? You have to give them an antagonist, something that will antagonize the effect of that drug. The commonly used drug is, trade name is called Narcan. And you give that, and if you're using a long-acting drug, like a long-acting narcotic, then you have to use, because the antagonist doesn't last very long, you have to keep the patient there until the effect of that drug has gone off, so that you may have to give them repeated doses of the Narcan. Now, the sedation and hallucination and drowsiness, you do become tolerant to that. But one thing that everybody gets, and there's no tolerance to, is constipation. It'd be nice if after a while you started having bowel movements if you're on these drugs for pain. But that's one thing that patients always complain about. So that's what we call differential tolerance. It does develop tolerance to some of the pharmacological effects, but it doesn't do to all of them. So that's important to remember. We've already talked about addiction and that it's more than just, well, let's see, let me go back to that, because the current consensus is that psychological dependence results from a complex interaction of biological, social, and psychological factors interacting with substance taking that produces a psychological. You may have, is that compatible with what they've said before?
Rather than talk about psychological dependence, I talk about it as substance dependence, not physical dependence. I make that.
Okay, all right. Okay, so it basically, the person who's taking this drug for recreational purposes is not just merely exposed to it. That's the take-home message. They've got other issues that are driving them to take this in spite of the fact that it's going to cause them harm. So how did we get where we are? You saw those two videotapes, and how did we get there? The short answer is education, societal cultural development, and institutional reinforcement. I'm going to talk a little bit about each one of those. In treating pain, the subject is poorly taught in professional schools, medical school, nursing schools, pharmacy schools, and any other allied health type of profession. When we first were studying pain from a clinical pharmacological point of view, the studies were done on people who had post-operative pain. In other words, you have the appendix out and it's painful. It's going to only be painful for 2 or 3 days. It's a self-limiting pain anyway. So they were done in that setting, and they were only given 1 dose of medication and said, here's a 2 milligram dose of morphine. Do you get any pain relief? And no, I don't. Here's a 5 milligram. Here's a 8 milligram. Here's 10 milligram. They said, well, 10 milligram works. So that's how that was established over a period of time in that type of pain. Well, at that time, cancer patients didn't live long enough for these types of studies to be done. They just died right off in a very short period of time. Now that cancer patients are living longer, we're able to study that type of pain, and we're finding that that is not the right dose. We know that, as I said before, the higher the intensity of the pain, the more of the medication that you have to have. So it was a lot of misinformation was put out there right as we began to study this from a pretty good intellectual point of view. And then we noted that the societal cultural biases, prejudice, and misinformation about pain treatment, especially drug use, begin to manifest themselves early in the educational process. Dr. John Morgan in New York coined the term opiophobia, and that means that the fear of using these drugs to treat pain. And I think he's retired now, but he taught pharmacology, and he knew what his students knew about treating pain. But then when he did a study and went back on the floors of the hospital to see whether or not they were doing it like he had taught them, he found out they weren't doing it like he taught them. Well, what's the problem? The problem is that the attending physicians have this bias based on our cultural and societal image of these drugs, and they would see these students write these orders, and they'd say, "Come here, I want to show you how to really do this, how the real doctors do this." And they would then inject their prejudice and biases into those young people, and out the window it goes, what they actually learn. So that the societal and cultural influences are very strong in this. And then also, because the individuals of a society make up the medical boards, the policemen and so forth, then they have that same prejudice, and that then is put into our institutions, and that continues to reinforce this. So it's very difficult to change that because of the reinforcement that you get from the institutions. Now, the societal and cultural factors started with René Descartes. He was a philosopher in the 15th century, the 17th century, I guess it is. And he basically was a major figure in the scientific revolution, and was also a major figure in the 17th century continental rationalism, and was associated with a well-known version of dualism. Now, what are we talking about? And when we say dualism, he's the one who basically gave us a concept that the body is separate from the mind, or the psyche is separate from the soma, the body, the soul, or the mind, and that the body works like a machine and is subject to the laws of physics. So if, as was stated by the doctor from the Medical Board of Virginia, is it doesn't get to the root cause of the pain. Well, what if you can't get to the root cause of the pain? So it's so imbued in us about there's got to be something wrong with the body in the way that it works, that we've got to find out what that is. And if it doesn't, if we can't do that, then it must be in your head. So the psyche is different from the soma. And so Western philosophy has embraced that. That was never embraced in Eastern philosophy. And so anything that you do in Eastern philosophy, Eastern medicine, is going to affect you no matter what. Here we have separated this, and so I've had some patients say to me so many times, "Doctor, now don't tell me it's all in my head." And you remember the young lady in the film said, "Well, she just made me feel like I was a head case, that I needed to see a psychiatrist." That still goes on. That still goes on. And that's just basically fundamentally because our culture has bought into this separation of the mind and body so strongly. So when we apply dualism to pain, pain is a symptom of some sort of bodily derangement. And fixing the derangement removed the symptom. Prior to Descartes, pain was considered a disease in and of itself. If you went into the doctor and said you had pain, that was a disease. And so now with Descartes, it means that if you can't find anything wrong with you, that it's even gone so far as to be imaginary. Okay.
I've mentioned this briefly earlier, but one of the most interesting findings in the last 5 to 6 years is that pain, if it's not adequately treated initially, can set up its own circuitry whereby the thing that caused the pain initially might be healed, but the pain is self-replicating. And therefore, as you're pointing out, you might not find, you find the injury is healed, but the pain is still there, and the people are called hit cases.
That's right. And then we can, and often we're coming to realize that chronic pain is a disease in itself. So that the thing has gone full circle. And we're getting more and more into holistic medicine, so that we are adopting more of the Oriental view of the wholeness of the individual, that anything that happens to it, whether it's psyche, soma, or whatever it is going to produce a change. So I think we're making some progress in that regard. The other thing I want to point out about dualism in practice is that derangement of the body can be objectively demonstrated. So objective and subjective becomes part of this same dualism that we talked about, psyche and soma. For instance, if you've got something wrong with your body, you can identify it either by physical examination, x-rays, CT scan, MRI, blood tests, and so forth. And then our society accepts that as proof. However, if the pain is not, if you're not able to do that, and it's subjective, then it casts a shadow on whether or not that pain is real. Subjective evidence against objective evidence. Which is more real? A patient with an elevated blood sugar of 350 milligrams per deciliter, when the normal is between 80 and 120, has a diabetes mellitus. Hey, he's got an elevated blood sugar. That's objective. You observe a beautiful sunset. That's subjective. Is that real? Of course it's real. If you see your son or daughter or brother or sister make a touchdown at the football game, you're thrilled. Prove it. I'm thrilled. No, you're not. So subjective experiences are just as real as objective experiences. A friend of mine, well, actually, it's Eric Cassells, who gave those topology of personhood, puts it one way: what chance has a little old lady with back pain, a complaint of back pain, chance does she have against a normal back x-ray? Put that x-ray up there. See, there's nothing wrong with your back. There's nothing that I can demonstrate. That's pretty arrogant, isn't it? But this happens over and over and over, degrading that person under those circumstances. So what is it about pain that causes this to happen? First of all, it's uncertain. You know that there's no pain and no word in our language for the word pain. I mean for pain, for something that hurts. We use pain, but the root word for that in both Latin and Greek means penalty or punishment. So you get the idea that you see where a stigma to a pain patient comes into the whole issue that we're dealing with here, is that back Go back to Job. What happened to Job? All of his friends left him. He said, what's wrong? You must have done something wrong. There must be a moral dimension to this problem that you've got. We don't want to be associated with somebody like that. So that's what people do when people have disabilities or whenever there's pain. For instance, people in wheelchairs will often complain about the fact that if they go through a place where they get their passport checked or something like that, they always talk to the person who's pushing the wheelchair. Does he have a passport? Why don't you ask him? This is the problem that they have in terms of the stigma that goes with disability and pain. Pain is subjective. It may exist despite no objective evidence, and only the person who's experiencing it can tell you what it is. And this is the problem sometimes, because there's nothing that you can see that you can put your finger on. We already talked about it being a stigma. And then we talk a little bit about the types of pain. And this adds to this uncertainty. That most pain is nociceptive. By that I mean there are receptors in your body, throughout your body, that will respond to painful stimuli. In other words, if somebody hits you with a bat, you feel pain because you've stimulated those nerve endings that's in there. They're called nociceptors. There are other, and that's in a setting of a normal nervous system. Your nervous system is intact. It will respond to that. Then you get into a situation in which there's damage to the nervous system per se. Then you don't have to have a stimulus to that pain. That pain can spontaneously occur. There are two syndromes that we have. One's called a post-mastectomy syndrome, one's a post-thoracotomy syndrome, where you see this occur fairly frequently. Now they don't do too much of this anymore, but in the days when you had radical mastectomies, taking off the breast and taking off the structures underneath the breast, and then just any type of breast surgery. The breast then heals up. The scar heals up. Everything is healed. And about 6 weeks later, you develop pain. And it's not ordinary type of pain. It's not the type of pain you get like when you get burned, or if you get trauma, and so forth. These are strange, unfamiliar sensations. They've been described as torque-like, where something is twisting. Burning pain is very characteristic of this type of pain. And anytime you get the nervous system damaged, remember in there where the man who was walking with the sticks with the interview with Ed Bradley said he had a automobile accident 5 years ago. He'd had several surgeries, and he got worse after every one of them. He's got neuropathic pain. They continued to damage his nervous system. And so he didn't have to have any stimuli. Nobody had to hit him with a bat. Nobody had to burn him or anything else. These were spontaneous pains that they had. And the other thing that's characteristic about these pains, which is very disconcerting, is that they don't respond to ordinary analgesic drugs. In other words, they respond to them, but they don't respond like nociceptive pain. Say, for instance, you, in an automobile accident, you break your leg. I can give you morphine and the pain's gone. In those patients who have neuropathic pain, You give them morphine and it dulls the pain, but it doesn't take it completely away. What we're finding now that there are two types of drugs that will help in that situation, and these are antidepressants. And so you tell the patients you're going to give them an antidepressant. They say, well, there's nothing wrong with me. I'm not depressed. Or anticonvulsants. And you see advertisements now on some of these, like for instance, Lyrica is an anticonvulsant, basically. And so you give patients, and then the other one is, what's the other name of the one you see advertised so much on television? Can't think of it right now. But it's a antidepressant. And the first generation antidepressants, drugs like Elavil or amitriptyline and doxepin and drugs like that, seem to be better than the other drugs, although the one I'm trying to think of is what's called an SSRI. It's a serotonin-specific reuptake inhibitor. You don't have to remember that. But then it can be serotonin, let's see, norepinephrine reuptake inhibitor, SNRI. Those types of drugs are proving to be helpful. And then I've had pharmacists that actually turn down prescriptions for that when the patient tells them that they're going to take that for pain, because they don't know that it works in pain. It may be a little bit better about that now. I have up there talking about the neuropathic pain. It occurs in settings of damaged nervous system, experience strange and unfamiliar sensation. It occurs spontaneously, and then it responds poorly to analgesic drugs. Now let's look at some of the cultural constructs about pain. And I put up here that's kind of a funny term, constructs, when used in this type of thing. And I've got two definitions. There's something constructed by the mind and a product of ideology, history, or social circumstance. Constructs about pain are based upon the dualism of René Descartes' separation of mind and body, psyche and soma, all aspects of the doctor-patient relationship, including how drugs are used in treatment, are determined by these constructs. Now that's important because that has to do with how well we're going to do in the future. I hope that if we make a videotape 10 years from now, well, actually we could do it now because that one is 96. That's more than 10 years ago. So, but if we made one now, we'd still have the same problem. Hopefully 10 years from now, we won't. These constructs are so ingrained in our society that they've become an integral part of our culture. And it is so much so that, from my own point of view, I think that for doctors to change, it's so ingrained that they feel like they're betraying their culture. And they simply don't do it. Of course, there are other things too, when you've got the DEA and the regulatory agencies that are breathing down your neck. Now, how this plays out in our culture, it plays out in the patient's narrative when you are talking about that. A physician can, if in the cases of women who have neuropathic pain, post-mastectomy syndrome. I had a patient one time, a very young woman, 20-something years old, who had a carcinoma of the breast. And she had a mastectomy and had immediate repair, construction of her breast. But then she developed neuropathic pain. And her mother-in-law would say something like this to her. Well, you know, Mary had something like that, and she never complained about all those things you're talking about, because she was talking about things that were strange. I have a twisting feeling. I have a burning feeling. And it may just occur spontaneously. She's getting ready to get a cup of coffee. She's crazy. And oftentimes I go to a doctor who doesn't understand this and says, "Doctor, I think maybe I'm going crazy." The doctor said, "I think you're right." That's really encouraging to her. And so this is one of the problems that we have. The laboratory and the imaging data trumps the patient's narrative. Just like I said, what chance does a little old lady have against who's complaining of a back pain who has a normal x-ray? And then treatment must be directed solely toward the cause of the pain and not the pain itself. In other words, if that person has pain, because of the dualism that we have, and there's a derangement in the body, I've got to find out what that is. And that's what the doctor does. And he keeps doing that. And then Descartes was also the first to associate the nervous system with pain. He thought that the pain came up through the nerves and went into the pineal body in the brain, and that was the seat of the soul, and that's how you had nervous pain. So if you just treat that, then because of the fact that it is so ingrained in our society, that's a cop-out. You're not really, it's just like the doctor from the Virginia board said, you're not really getting at the problem. So maybe you try to get at the problem over and over again. And that's what I call the tyranny of Descartes. Why don't you just give them something to relieve their pain? Why don't you give them an analgesic drug? Now, we are getting more and more people who are doing that now, but we still have this problem. Opioids' potential harm to society trumps adequate treatment of pain with opioids. What did that guy say when he said that this man's wife said her husband would still be alive if Dr. Hurwitz still had his license so he could simply treat the pain? He said, as tragic as that may be, I still think we do a good job. So that shows you how much it's ingrained. And I've said before about the number of individuals harmed by illegal use of opioids and other mind-altering drugs pales in comparison. We have millions of people who can't get adequate pain treatment. We use a small group of people that cause our society harm. The other part of it, the doctor-patient relationship of honesty, integrity, and mutual respect is destroyed. What do you do? Nowadays, the regulatory agencies are putting all types of restrictions on that relationship. First of all, you have to interrogate the patient as if they are a criminal. It's a criminal interrogation. You got any brothers or sisters that are on drugs? You've got to give me a urine test now. I want to see whether or not you're already on drugs. And they count marijuana in that situation. If you're on marijuana, you might as well go home, because chances are you're not going to get anything more than aspirin or acetaminophen or something like that in a lot of cases. All through the course of your treatment, you're going to be subjected to this type of monitoring, where you're going to have random samples of drugs. Number one, do you have what I am prescribing for you in your urine? Because if you don't, you must be selling what I'm giving you. And do you have anything other than what I'm giving you in your urine? And those tests are not always that good. I had a patient one time who was a pretty simple guy, and he kept telling me that the drug that I was prescribing for him wasn't doing him much good. And so I thought that he was, you know, maybe something was wrong. So I told him, I said, and so I had a urine test done on him, and he came back negative, didn't have anything in there. So I told him that I wanted him to come in, to take his medicine like he ordinarily did, come into the hospital, and then I'd give him another dose of that medication. And then I'd take a urine sample right after that, and I had to watch him so I could know that I had a chain of custody for that urine sample. So I watched him urinate in a urinal, took it to the lab myself, and there was nothing in it. Then I had it 2 hours later where he should have metabolized that, and there was nothing in it. Well, we then went to the lab to see what the problem was, and they were not reporting the drug unless it was exceeded a certain level. So here I was accusing this guy of all sorts of bad things. Not actively accusing him, but in my mind I thought something was going on, when actually they weren't doing the lab test right. All I wanted to know was if anything in there, period. So those things, that's demeaning to the patients. You're degrading, that you've destroyed that type of relationship. And this is what our society is doing. Also, they're putting on requirements of a contract. What kind of deal is that if you got to make a contract with your doctor that you're going to be honest? I'm not, I oppose these vehemently, but it doesn't do any good. It's a demeaning, it's unilateral. The doctor doesn't have to do anything, but the patient has to do all of this. And if they break the contract, it's out the window they go. They have to go someplace else. So that's a big problem. Then we see that these regulations and these constructs about objectivity and subjectivity have gotten into the regulatory agencies. The state regulatory agencies are the ones that license and discipline the boards. They're the medical, nursing, and pharmacy. Texas has made an effort to ameliorate this barrier. We were the first to pass a intractable pain treatment law in 1989. We found out that that didn't do too much good, and we asked the board in 1995 to make some rules. When a board that is given rulemaking authority by the legislature makes rules, that has the same effect as a law, because they're simply acting as a surrogate for the legislature. And they changed the rules, and we thought that would help a little bit. We also asked them to do away with the triplicate prescription, which is when you write for a Schedule II drug, you have to write on three copies of a prescription. The top copy goes to the pharmacist, well, it goes to the patient, goes to the pharmacist. The top two copies. The top copy goes to the Department of Public Safety, and the second copy, the pharmacy has to keep it for 2 years, and the third copy, the doctor has to keep it for 2 years. We got that law repealed in 1997. We almost had to go to court to get them to enforce that. Now we have a state-issued single copy prescription that is better than the triplicate, but it's still monitored by the state. So the state can take your license away. Also, if you're doing something criminal and they investigate you in the state, you can also go to jail. But in the federal system, they enforce the Controlled Drug Act of 1970. And most all of that is criminal because the federal government has no control over licensing doctors to practice medicine. That the state does that. Now that the federal government, the DEA, does issue a license to prescribe controlled substances, and they can take that away from you. And that's what they did with Dr. Hurwitz. He said he got his license back, but the catch was he couldn't prescribe narcotics for a year. That was the DEA that wouldn't let him do that. So, and if the DEA is not going to let him do that, the state's not going to let him do it either. And the consequences of the federal problems is that you can go to jail, just like Dr. Hurwitz did. The other thing that we have to admit is that these constructs are enforced by academia. There's a lack of uniform standards of practice, and differences in practices among pain physicians result in adverse consequences from internecine conflicts. That internecine is just a fancy word for fighting among yourselves. And so what this does, it pits the pain treatment specialist against the family practitioner, because the pain treatment specialist is most often going to look at the objective part of the problem in terms of whether or not you can demonstrate something that can be corrected. And that's what they do. They give injections, they do operations, they do other things like that to correct malfunctioning in the body. Oftentimes you can see some non-alignment of vertebrae in the backbone, and you say, aha, that's what causes it. The patient gets operated on, and what do you have? That wasn't what was causing it. You still got the pain, and then now you've got neuropathic pain too. So that's what happens when they get worse after that. So the tyranny of Descartes is the pursuit of objective, rational treatment beyond practical and the best interest of the patient. What if a patient just says to me, you know, doctor, I don't want that operation. I'd like to have morphine. Morphine relieves me fine. I can get along just fine. Just give me morphine. Is he going to get that? Chances are he's not. What is the doctor going to think? He's going to think he's a drug addict. And so this is a tyranny of Descartes. Your choices are not to, well, actually, options doesn't include you having morphine for an indefinite period. Now, the state of California has passed a patient's Bill of Rights trying to correct that, but it hasn't worked very well. So basically, you're pitting the pain specialist against the family practitioner. The pain specialist will do these procedures up to a certain point, and he sees that they're not working anymore, and the guy says, I'm not having any more of those. And the guy says, okay, go back to your regular doctor. And so the family doctor puts him on morphine, and what happens? The board gets on the family doctor for giving the morphine, and when they have a hearing, who testifies against the doctor that gave the morphine? The one that was doing the procedures that do not work anymore, because he's the expert. So this is one of the big, big, big problems. I'm telling y'all secrets. trade secrets here. But the phrase tyranny of Descartes should not be interpreted as intellectual. You know, we need to look at causes of pain and relieve those if we possibly can. But in our present state of knowledge, insisting on exclusively an objective, rational approach to treatment with its known limitations deprives patients of effective, subjective, empirical treatment. And this is one thing that I really object to in terms of how we treat patients in pain at the moment, because all the evidence shows that they don't get addicted, that they don't have all these problems, and that this provides a better quality of life. So, but we do want to do continued active research for correcting or removing cause of pain should be encouraged. So let's summarize here now. I think it's getting close to quitting time, and then you can have any questions you want if you're still awake at that time. First of all, drugs with effective and legitimate medical uses are also abused by individuals for non-medical recreational purposes. Individuals who abuse these drugs cause significant societal harm to themselves, others, and property. And this is the image that most people have of these drugs. The societal harm image of these drugs dominates society's concept of them. Psychoactive drugs are the ones most commonly abused. We did say something about the performance enhancements of the male hormone. The effective and legitimate use of these drugs is negatively influenced by the societal harm image of them. The societal harm image permeates societal institutions, which perpetuates and enforces a negative image. Societal institutions, regulations contribute to inadequate treatment of pain, especially chronic pain. The societal harm construct of abused drugs is so ingrained in society, it's become part of our culture. The societal and cultural constructs about these drugs must change before any meaningful improvement in pain treatment will occur. And that sums up the treatment of pain and the specter of drug abuse and how it influences and limits what physicians do with these drugs that are so effective and can be used properly. So, has anybody got any questions? Yes, sir.
What are the circumstances when a doctor would prescribe methadone for pain, not replacement therapy, but for someone with pain? Under what conditions?
The question is, why would you prescribe methadone for pain rather than for maintenance therapy? I mean, drug abuse treatment. Yeah, okay. Well, methadone is a very good drug. It has a long half-life, so it lasts a long time. That's the reason it's used in drug abuse. In drug abuse. So, it was developed by the Germans during the World War II because their access to opium was cut off. So they had their chemists to synthesize this synthetic opioid, and it's very good. It has a long half-life, anywhere from 13 to about 35 hours. So that means it stays in the body. That doesn't give you pain relief all that time. It'll give you pain relief anywhere from 6 to 8 hours. So that's the good part of methadone. However, then when you give other doses, it just is an additive effect, so it's a little bit more difficult for the doctor to handle that. And that's one reason it's not used as much as it is. It's very cheap. That's another reason that doctors should be using methadone. You have to have a license, a special license, to use it for drug treatment situations. In other words, an ordinary doctor, if it doesn't have that license, cannot use it for that purpose. They can only use it for the treatment of pain. Selecting it probably doesn't relate to its pharmacological effect in as much as it does to the cost factor. It's a cheaper drug, and it does a good job. It's just harder for the doctor to get the right dose, because at the end of about a week you have to be careful, because it's built up to a pretty constant equilibrium, and patients may then have too much. So you may have to adjust that. And other drugs, these long-acting drugs where they release the drug over a longer period of time, it's easier to handle. They're much more expensive. So those are the considerations. Price probably is the main reason that you might just select that as a cheaper drug.
Would it ever have to do with the doctor didn't trust that patient if they were already on some form of other pain meds and just wanted to put them on methadone didn't trust them or something for that pain?
Whenever you have to change them to what's called an equal analgesic dose. In other words, say for instance, take a drug like morphine, and then take one like hydromorphone or Dilaudid. Dilaudid is 5 times more potent by weight as morphine. So an equal analgesic dose of Dilaudid is 5 times less than what it would be if it were morphine. In other words, if I gave you 10 milligrams of morphine orally, I could give you 2 milligrams of Dilaudid, and that'd be the same thing. So you'd have to calculate what that equal analgesic dose would be for methadone from whatever you were switching them from if they were on another drug. And in general, you don't keep them on 2 drugs that have the same mechanism of action, like methadone and morphine. They're both mu agonists. They bind on the mu receptors in the body, and so you wouldn't want to. You might use methadone for long-term pain, and then if they had what's called breakthrough pain, like for instance, if you have pain, constant pain, and you fell down, and that pain exacerbated, that's what's called breakthrough pain. It broke through that control that you had it on. Then you'd give them a short-acting drug like morphine. So you use it that way in combination. So, yes, ma'am.
I was very interested in what you said about treating neuropathic pain with antidepressants and anticonvulsants. And my question is, have there been clinical studies related to that, or are you prescribing these medications off-label for your patients?
There have been lots of clinical studies done, particularly by Howard Fields and his group at UCSF. And lately now, with some of these other more modern antidepressants, the SSRIs and SNRIs, they've been shown to be pretty effective in studies. But they've gone back, 15 years ago, when they first using the tricyclic compounds like amitriptyline and nortriptyline and doxepin and drugs like that. And basically, because of those, they have more side effects than the newer drugs. And maybe it's the side effect part of it that helps with that. We don't know that for sure. But then the other ones are that way too. So, and then also drugs like tramadol, they have they're mu agonists, and they're also like a tricyclic drug. So it's a combination of that. So that could be helpful in that particular case. Okay.
Pressing question that always gets asked is how can you tell the difference between somebody who is really in pain and somebody who's simply drug seeking?
Oh, that's an easy answer. You can't. There's no way that that you can actually prove that somebody has pain. That's why you have to believe what the patient says. I was on the committee that published the first guidelines that were ever published on any subject was on the cancer pain, and that was one of the main things we put in there. You have to accept what the patient tells you. Now, obviously, if you get into a situation where you know that they're doing something with this, if if you see them on television selling drugs on the corner, then you've got to be careful about that. But you really can't. There's a condition of operant conditioning where, for instance, if I come in all bent over, then I'm acting out what pain looks like. If I come in and say, God, I got this terrible pain over here in my back, yeah, and I like to go down here to the bar and have a drink. You say, well, there's something, a disconnect there somewhere. But you really cannot do that long term. You have to take a bunch of factors into consideration. But I think that the rapport and the good relationship is the basis of that. Did you have a question?
Well, just following up on what Dr. Robbins asked, I mean, if an individual is seeking the euphoric aspect of the opiate, and to keep that euphoric aspect, you have to significantly increase dosage pretty frequently. Would that generally be an indicator that this is abnormal? If the average for, if you're working with cancer patients of a certain type, like this is kind of in the norm, and then this person, it's like, wow, they're increasing dosage by 500% of what these people are doing.
That doesn't help you. Doesn't help you, because, for instance, if you have a pain scale, say 0 is no pain at all, and 10 is the worst pain that you can think of, and you put down 5, and you've got, let's say you burned half your leg off, and somebody got a pinprick and they put down 8. You can't compare those between two individuals. The only thing that the pain scale is for is comparing it whether or not you're getting that particular person better. In other words, you have to use that pain scale for that person. But you can't say, oh, well, look, you put 8 down. Well, Joe put down that he's only 5, and he's got a worse condition than you do. See, so you don't have any pain. Get out of my office. So, okay. Thank you very much.